So a very warm welcome to today's Wolfson guest lecture on health, environment, and architecture. It gives me great pleasure to introduce our speaker, Matthew Eddy, who is professor and chair in the history and philosophy of science at Durham University. In addition, he is co-director of the Institute of Medieval and Early Modern Studies and co-director of the Center for the History of Medicine and Disease. Before coming to Durham, Professor Eddy worked at various institutions such as Princeton University, MIT, Harvard, Caltech, and Uppsala University. As a cultural and intellectual historian of modern Europe, he focuses on the cultural history of science in modern Britain and its former empire. He's especially interested in how different social groups use science and its attendant media technologies to make competing knowledge claims about the nature and the body. His work has been supported by the British Arts and Humanities Research Council, the Wellcome Trust, the Mellon Foundation, the Swedish Riksbankens Jubileumsfond, and the Royal Society of London. Among his numerous publications, I would like to single out his two monographs. The first is The Language of Mineralogy, John Walker, Chemistry and the Edinburgh Medical School, 1750 to 1800, that was published in 2008. And the second monograph is Media and the Mind, Art, Science, and Notebooks as Paper Machines, 1700 to 1830, published just last year. He is currently involved in several different research projects. One of them deals with the historical and ethical relationships between race, cognition, and democracy within the lives of Black physicians in the British Empire. His guest lecture today is directly related to this project. The title is, as you can see, Architect of Information, Race and the Environmental Health Models of Dr. James Africanus Beale Horton in British Africa during the 19th century. Matthew, we are very much looking forward to your lecture.
Thank you very much for such a generous introduction. I'm delighted to be here, and I would like to thank you for asking me to speak. So I'm going to just jump right into this. This project, as was just mentioned, is part of a larger, this paper is part of a larger project, and which I'm interested in how Black physicians trained in Britain during the early 19th century, how they used information to try and achieve health equity and within various places around the Atlantic world. In this case, we're looking in West Africa, but I also have other cases in the Caribbean and in North America. So I'm just going to launch straight into it. You have to forgive me, I'm just getting over COVID, so if I start coughing, that's the reason why. So information is often characterized as facts that float effortlessly across time and space. But during the 19th century, and even before, information was seen as a process that included a set of skills enacted through media on a daily basis. Media systems, much like buildings and roads, had to be designed. And much like architects, information engineers had to think about a host of material and social issues when they created data. This was especially the case in colonial settings such as British West Africa, where the structural inequalities of race influenced the design of health models and the collection of inadequate medical and climatological data. But there were a number of 19th century Black physicians who challenged this architecture. One such physician was Dr. James Africanus Beale Horton, who lived from 1835 to 1883. And in this paper, I'd like to examine the role he played as an information architect who sought to re-engineer the relationship between data and disease in the media systems that the British used to manage health in mid-19th century colonial Sierra Leone. And the image on my slide here is an 1850s watercolor of Freetown. So this would have been the backdrop of the city that he grew up in and then eventually returned to. Let me try and change my slide. There we go. So I'd like to first introduce Horton, Dr. Horton, to you. So in the autumn of 1866, the British military sent Dr. James Africanus Beale Horton to assess a yellow fever outbreak that had erupted at Bathurst Military Station on St. Mary's Island at the mouth of the Gambia River in West Africa. Horton was both a physician and a military officer who had been educated in Britain and was based in Freetown, Sierra Leone. At the time, St. Mary's Island was a British military base that played a strategic role in controlling the coastline around the Gambia River. In other words, the British military was sending a highly educated, well-respected African physician to assess the outbreak that was occurring in a key military location. And this leads to the following question: who was Horton, and how had he become an expert who understood the information architecture that disseminated tropical health data to and around and away from British West Africa? And here on the slide is an image of Horton. It's one of the two that I've been able to find on the right. So Horton was born in 1835 in the mountains of Sierra Leone to parents who had fled North American slavery. In addition to his medical training, he had direct local knowledge of West African diseases because he had grown up there. After receiving his secondary education at Furrow Bay College in Freetown, which, by the way, Durham has part of its archive here, later years, he was educated at Furrow Bay College in Sierra Leone, and Horton then went on to study medicine at King's College, London, from 1855 to 1858. In fact, if you go to one of the main buildings at King's College today, they have images of famous graduates, and they have just added Horton to this list, which I was delighted to see over the summer. So Horton took his surgeon's license in 1858 upon finishing at King's College. And then this was followed by a medical doctorate at Edinburgh University, which he received in 1859. And while in Edinburgh, Horton wrote a dissertation entitled On the Medical Topography of the West Coast of Africa, including sketches of its botany, and botany being relevant because it was helpful for understanding local drugs. And this thesis is on the slide here. This is the handwritten title of the thesis, still at Edinburgh's archive. And it was subsequently published in 1859 under the same title by the well-known medical publisher John Churchill, who was based in London. After Horton's time in Britain, he returned to Sierra Leone, where he was appointed a British military officer and served in the colonies and territories of British West Africa. In this capacity, he distinguished himself as an international expert on tropical medicine by collecting medical and environmental data related to public health. From the 1850s to the 70s, he used this data when he published articles in newspapers, as well as in scientific journals, such as the Army Department Medical Report, which is the image of one of his articles on the left. Over the course of his career, he also published several well-received books, with his most influential one being titled West African Countries and Peoples, British and Native, which came out in 1868, and the title page is on the slide. So during Horton's studies, Britain's medical establishment was coming to terms with what Ian Hacking, the historian and philosopher, has called an avalanche of numbers. And this was data generated by the explosion of state-driven record keeping that arose in Europe, including Britain, between the 1820s and 1840s. Though data-driven reform measures increasingly were used in public health decision making in Britain during the 1850s, the same principle generally was not applied to British colonies. In what remains of this paper, I would like to explore how Horton used his skills in data science, as it would have existed at the time, to identify a number of problems with colonial data collection, and then how he proposed a new architecture of information that would help improve the health of everyone who lived in British West Africa. So that is Horton, and that's his background. I'd like to now introduce you to a few data models that he was using to understand health during his training and then when he went back to Africa. So as shown by Mayabe, Ikuku Isaka, Rana Hogarth, and others in the titles of their books here on the slide, from the late 18th century onward, Europeans developed a causal model of epidemiology that treated African bodies as being constitutionally different from European bodies. And we might call this causal framework a constitutional model because it focused explicitly on select aspects of the body's physical constitution. Constitutional epidemiology stood in contrast to a second model, which treated the environment as a main cause of disease. And Horton was a staunch advocate of this environmental model in his publications. Horton's understanding of the environmental model was significantly influenced by Sir James Ranald Martin's 1837 book, Medical Topography of Calcutta. Martin's work showed Horton that when statistical data was collected for Asian and European communities that lived in relatively the same location, it could be seen that disease impacted both groups in a similar manner, thereby supporting an environmental causal model. Inspired by Martin, Horton collected West African data with a view to dissociating the relationship between disease causation and essentialist epidemiological models based on race. And there's a map on the slide here that Martin published in his book, in which he uses throughout the book to show the proximity, the nearness of various communities from which he collected data because he was interested in topographic locations and that kind of impact on disease rates. So Horton's studies in Britain had taught him that the joint use of temperature and mortality data could be used to understand the spread of epidemics. And his thoughts were influenced by the work of the apothecary and statistician William Farr, whose work offered data which suggested links between climatic causes and illness. Additionally, Horton's medical courses with statistically minded professors such as William Augustus Guy at King's College had showed Horton that inaccurate or incomplete climate and mortality data oftentimes meant the difference between life and death when used in the context of public health decision-making. So these are the data models that Horton was working with when he was thinking about West Africa. And now I'd like to look at what I'm calling a data deficit, that is a gap in the data that Horton identified. So medical statistics regularly informed Horton's publications about the relationship between equity and health in British West Africa. The most thorough expression of his thoughts on this subject were given in his 1867 book, Physical and Medical Climate and Meteorology of the West Coast of Africa. And I have the title of this book on the slide, and I'll refer to it throughout the paper as just Physical and Medical Climate. Throughout the book, Horton underscores his conviction that the biggest obstacle to effective environmental health management decision-making in West Africa was a data deficit. That is, the absence of a useful cache of climate and mortality data. Additionally, the extant data was oftentimes limited and organized via categories based on racial stereotypes drawn from the constitutional model. As shown by Tim Lockley, a historian, even at the level at the British Army Medical Department, for whom Horton worked, the constitutional model of epidemiology contributed to detrimental and oftentimes deadly assumptions about the health of Black West Indian and West African soldiers. It created a situation in which race was being used effectively as a sorting technology, as a tool described by Ruha Benjamin in her work to categorize information about Black bodies and populations. Using race this way prevented resources from being dedicated to the collection of accurate data and contributed to colonial statistics that reinforced structural health inequality. And so before I turn the slide, I mentioned this is the title of his book. The other pictures of Horton himself, which was taken right about the time that he had left England after his studies. And I suspect he probably wanted to use it as the frontispiece of the book, but it ended up not happening. But you can see him in his military uniform here. So the problem of inaccurate data with health statistics was recognized by many British authorities, particularly physicians such as Edmund Parks, who worked in the Army Medical Department's research hospitals. And here we have an example of the Royal Victoria Hospital in Netley. This was a research institution with an enormous library and many experiments and studies being conducted there. And Parks was a professor here at the hospital. And the section on health statistics in his influential book entitled Practical Hygiene, which is cited numerous times in Horton's work as well, Parks warned of the dangers of gathering irrelevant, what he called numeric units, of sorting data into, which would then lead to sorting data into erroneous groupings. Horton's usage of Parks and other medical statisticians in physical and medical climate reveals that Horton was well positioned to understand the advantages and drawbacks of incomplete or erroneous clinical data. Horton also approvingly cites William Farr, the innovative medical statistician I mentioned earlier, whose 1852 graph and in his book Report on the Mortality of Cholera in England reconfigured the way in which Britain's medical community understood the importance of using abundant, accurate temperature or mortality figures to understand the spread of epidemics. And here is Farr's book and his now well-known to those who study history of epidemics and visual technologies. So based on Horton's use of statisticians like Farr and Parks, and on Horton's wider clinical training in both London and Edinburgh with statistically minded professors such as Guy, Horton understood that these inaccurate data were causing problems in the accurate prediction and understanding of West African health. And so when he applied these principles to West Africa in the colonial context, it revealed the health data of the area was limited because it was basically related only to troops. And the general population was effectively not measured in a sense of their health. Indeed, Horton's physical and medical climate underscored the fact that the health of African and European civilians was largely unrecorded, and there was no consistent system of keeping climatological records, even in the military stations that the British had in West Africa. And the coastline, I should add, was, this was 2,000 miles of coastline. These colonies were spread across, or territories. Now, this meant that the health and climate statistics based on the extant West African data were effectively unviable because they did not present an adequate sample of climatological readings or death rates of the full population. Notably, Horton's desire to provide more West African data fit within the Army Medical Department's growing realization that it often lacked appropriate statistical data from colonial locations. And this sentiment was articulated in 1864 by the aforementioned Edmund Parks, who we will call was professor of military hygiene at the Army Medical School and worked at Netley. And Parks observed, and I think this is a really interesting quotation, quote, even in the Army returns, and the returns are these statistics sent back to England from the colonies of data of sickness. Parks says, quote, even in the Army returns, which are all furnished by qualified practitioners, there is reason to doubt the correctness of the earlier data tables, especially. And so what he's saying, earlier data tables, these are basically anything before the past few years, right? So he's writing this in 1864, which meant that there was a general, based on someone who was an expert with all this data at his fingertips, was convinced that it was not even accurate across a lot of colonial settings. And Horton was extending this by saying, well, we need to think about West Africa as well. So that's the data deficit. And I'd like to now look at what Horton decides to do. So to solve the problem of data scarcity, Horton generated or collected data from local sources during the 1860s and 1870s so that he could implement Martin's model, that is James Ranald Martin, who we heard about before, working in India. And he collected the data because he wanted to empirically also disprove constitutional epidemiology's claim that Africans were less susceptible than Europeans to tropical diseases. And in my project, I call this kind of information counter data. And this notion of counter data has been developed by scholars working on the agency of subaltern activists. And as explained by Catherine D'Ignazio and Lauren F. Klein, counter data is quantifiable evidence collected about, and oftentimes by, subaltern or minoritized communities who have been ignored by information ecosystems created by those with political or financial power. And the aim of collecting and disseminating the data is to give such communities the power to obviate and foster meaningful change. And so Horton starts to collect this data during the 60s and 70s. And this slide indicates some information about this. On the right of the slide, we have a register of births and various other health issues that was kept in a local city. And Horton used not this one, but ones like this. This is from Sierra Leone to compile data. So he's going through the manuscript sort of evidence that is around him in Freetown or being gathered into Freetown. He's doing also temperature readings across the coast when he's at different stations. So you can see here on the map of West Africa, these are all of the British stations. And at one point, except for Monrovia, that's not a station, that's just a city. But the rest of them are places where Horton would be stationed for a week or a month or so. And while he was there, he'd be taking climatology readings and also trying to find local records. So in 1867, Horton collected all of his reports and his data into scores of tables and published them in his Physical and Medical Climate, which I mentioned earlier. Now, time prevents me from going through all the data in Horton's book. However, it will suffice to say that it can be divided into two kinds of synoptic information: mortality tables and climate tables. And I have an example of each here. His book presents page after page of such tables, making it easily the most thorough single source of environmental health information for West Africa during the mid-19th century. Throughout the book, Horton used his data tables to show how topographic factors, not racialized body features, directly impacted health. A case in point is his book's account of the 1866 Bathurst yellow fever outbreak on the Gambia River that I mentioned at the start of this paper. Using his tables, his new tables, he explained that the genesis of the outbreak was environmental causes indigenous to the island's topography. And here is a slightly contemporary image of the station at Bathurst. So in Horton's words, quote, local atmospheric causes, unquote, related to the ways in which temperature and humidity facilitated the emergence of fetid vapors in the mangrove swamps around the station was the main culprit of the disease. As such, the outbreak was, quote, purely endemic, unquote, and, quote, confined only to a very limited area, unquote. Throughout his works, Horton offered similar links between disease and climate data when discussing outbreaks for the individual cases of patients he treated in hospital or in his private practice, thereby further undermining the racialized constitutional model that was being used by various European colonial administrators. So what happens with Horton's information? And this is a question that is difficult to answer because Horton is not someone that has attracted the research of major historians of science or medicine. So all of what I've been able to pull together here, which is quite interesting, has been against the grain, so to speak, in terms of having to just do it on my own and dig through many sources and find out what happened. So what exactly happens with this data? So Horton was keen for the data in his physical and medical climate to be disseminated. Having published op-eds, articles in the African Times, he was aware of the power of newspapers and print to distribute accurate information about, or just information about West Africa. But instead, he targeted what he called, and I love this word, the, quote, executive machinery, right? He targeted the executive machinery, that is, politicians and administrators responsible for setting and implementing imperial policies. So he's aiming for the top. The chief wheel of this machine, to extend Horton's metaphor, was the British Parliament, and its power over policy, law, and resources turned other medium-sized decision-making wheels, such as government departments, like the medical department that Horton worked for. And for every colony, there was a smaller wheel, which was comprised of the governor and the local civic, commercial, and military leaders. Horton wanted his data to be distributed amongst parliamentarians amenable to granting the West African people resources to support the creation of a self-governed colony, which was able to collect and disseminate accurate public health data. He accordingly dedicated physical and medical climate to Edward Cardwell, who was an MP who had served as Secretary of State for Colonies between 1864 and 66. This followed a similar strategy of other Black activists during the 19th century that dated at least as far back as 1823, when the mixed-race Edinburgh-educated medical doctor Jean-Baptiste Philippe sent a 300-page report to the Secretary of the Colonies, Lord Bathurst, which advocated for the physical and social well-being of free Black citizens living in Trinidad, which was a British colony. And so here's a contemporary image on the right of Cardwell from the National Portrait Gallery, a caricature. So in addition to Cardwell's connection to colonial management, Cardwell was a Liberal member of the House of Commons, and he played an active role in the 1865 Parliamentary Select Committee that had been tasked with investigating the structure and autonomy of Britain's West African colonies. Cardwell supported African self-government to an extent and had the political connections to circulate Horton's book and its important climate and mortality data. Whereas Cardwell does not seem to have commented directly on the data presented in Physical and Medical Climate, it is clear that he was impressed with Horton and possibly his efforts, because next year, in 1868, he met in person with Horton in London to discuss the West African colonies. During the meeting, Horton presented Cardwell with a copy of his recently published new book, West African Countries and Peoples, which made further recommendations relating to the collection of health data in West Africa. In addition to meeting with Cardwell, the Adjutant General for Africa presented Horton to the royal family on the 30th of May, 1868, and the event was recorded in the African Times with the following summary, quote, "At the levee at St. James's on the 30th of May, by His Royal Highness Prince of Wales, on behalf of Her Majesty, we find among the presentations Dr. J. Africanus Beale Horton, Staff Assistant Surgeon by the Adjutant General." And we have a contemporary picture here of Prince Edward from the same year that Horton met with him. So what does this mean? So a few words of conclusion. So Horton's meetings with Cardwell and the Prince of Wales opened an extraordinary political door and represents the only known instance when a 19th century British politician or member of the royal family met in person with an African subject who was a statistical expert and who had written on the health and climate of West Africa. Though Horton does not seem to have maintained contact with the royal family, his data-driven views informed his thinking in the letters that he subsequently wrote to Cardwell over the following years, and these have been since published. In many respects, Horton's search for counter data was an act of countervalence, a way of leveraging the British state's vested colonial interests in the health of its West African soldiers and civilians against the discriminatory assumptions about the people and climate of the global South. Horton sought to speak truth to power by using the language of climate and mortality statistics. He believed that his evidence had the potential to obviate the misguided assumptions that underpinned the constitutional epidemiological model that he hoped that liberal politicians and statistically literate managers of the Army Medical Department would see the value of committing the resources to collecting more West African public health data. Despite Horton's best efforts, the British government declined to commit its resources to supporting the creation of a data infrastructure capable of sustaining empirically informed public health decision-making in West Africa, thereby making it more difficult for African scientists and physicians to challenge constitutional epidemiological theories based on racialized models of health management. But Horton was nevertheless a visionary who diligently sought to place his considerable knowledge of medical science in the service of West African health equity. Rather than seeing Britain's colonial information architecture as a fixed entity, Horton offered an equitable vision for recalculating the equity of public health in British West Africa. Thank you.